Hello everyone and welcome back to my channel and good morning. Okay, so we have started the preparation for gynecology subject and we have already discussed some topics in the previous video. I have uploaded 3 videos. So we have discussed the amenorrhea, menorrhagia, and dysfunctional uterine bleeding, and the postmenopausal bleeding, secondary dysmenorrhea and menopause. And in the third video I have discussed the abortion, the recurrent abortion, the septic abortion, the incomplete and threatened abortion. Now in this portion we are going to discuss the ectopic pregnancy, the endometriosis, and adenomyosis. Okay, so starting from our first topic of today, that is ectopic pregnancy. So first we will discuss the scenario for a topic, then we will discuss the definition and the site and the causes. This is a revision session and we are going to discuss the topics that how the patients arrived in the OPD with what complaints and what are the clinical features of a specific disease, and then how we will investigate that patient and what are the treatment options and what are the causes of the specific disease. So this is ectopic pregnancy. We are having a scenario that there is a 19-year-old para 1 presents with gestational amenorrhea of 6 weeks, bleeding PV, and severe pain hypogastrium. So give the differential diagnosis and the management. Then the scenario is that there is a P3 with gestational amenorrhea of 6 weeks with lower abdominal pain and spotting since 1 day. So what are the differential diagnosis, investigations, and the management? So here we comes to know that there is the bleeding history and the abdominal pain history, and spotting signs are present, and she is para 3 and pregnant for 6 weeks or 8 weeks. So what is ectopic pregnancy? The implantation of fertilized ovum at the site other than the uterine cavity is ectopic pregnancy. The sites are fallopian tube, ovaries, abdominal cavity, and the rear sides are broad ligaments, rudimentary horn of the uterus. Now, the causes of the ectopic pregnancy are pelvic inflammatory disease, tubal surgery, that is conservative surgery for the ectopic pregnancy, sterilization and tubal reconstruction, tubal diseases, intrauterine contraception devices, diethyl stilbestrol exposure, termination of the pregnancy, assisted reproduction techniques, and ovum transmigration. And the assisted reproductive techniques are IVF, GIFT, and ZIFT. Okay, the differential diagnosis of the ectopic pregnancy are fibroids, subserous fibroids, spontaneous abortion, ovarian pathology, corpus luteum hemorrhage, acute PIDs, appendicitis, UTI, uterine colic, and perforated peptic ulcers. The clinical features are amenorrhea, abdominal pain, vaginal bleeding, and other are shock, subject to symptoms of the pregnancy, syncope, and shoulder pain. The investigation options that are done for the ectopic pregnancy are general physical examination, that is tachycardia, hypotension, hypovolemic shock, blood pressure, skin pale, and cold climate. These signs are present in the ectopic pregnancy. Abdominal examination is done, which will be rigid and rebound to the tenderness. Pelvic examination is done, it will be dark, blood will be present. On speculum examination, bimanual examination is done, severe pain will be present, and cervix of the uterus is checked. On ultrasound, the abdominal ultrasound is done, vaginal ultrasound is done, and Doppler ultrasound is done. Serum HCG is checked, which is very accurate and has 10% results of the fertilization, then urine HCG level for pregnancy. Laparoscopy is done, which is indicated in difficult cases or when serum beta HCG or vaginal ultrasound. Colpotomy is done, which shows the intraperitoneal hemorrhage, and progesterone is done, which shows the depressed level of the progesterone are present in with the ectopic pregnancy and below the 15 nanogram per ml. The pre-treatment investigations for the ectopic pregnancies are full blood count, assessment of the degree of the anemia, the blood grouping, and the cross-matching of the blood transfusions, and the rhesus prophylaxis. Now, the management options are conservative management, medical management, and surgical management. Surgical treatment is a treatment of choice, and the choice of treatment depends upon the state of the ectopic pregnancy. Ruptured, unruptured, asymptomatic. The condition of the patient, past history, and desire for future pregnancies is should be find out is before the surgical treatment. Now the initial measures to taken are, that is, it is medical emergency, so the patient, if comes with shock, should be resuscitated immediately by HO or MO or staff nurse. Then 2 wide bore cannula should be inserted in 2 different limbs and take blood from the patient and send it for routine investigations and cross matching. Then arrange blood and start blood transfusions. Monitor the vitals, that is blood pressure, temperature, and pulse. Place urinary catheter for input output and manage hemorrhagic shock by rapid infusions of the ringer lactate. Then give local anesthesia if required. Now laparotomy is done, which is indicated for the rupture of tubal pregnancy. Patient hemodynamically unstable. When laparoscopy is contraindicated when ectopic pregnancy is in rudimentary horn of the uterus. Then give a small fenestrial incisions that start suction of the blood and search or locate the bleeding point and stitch it. The parotomy is medicated if there is tubal rupture and if patient is hemodynamically unstable or when laparoscopy is contraindicated. The corrective procedures are salpingectomy and tubal repair, partial salpingectomy and salpingotomy. The laparoscopic surgery is both salpingectomy and conservative procedures performed at laparotomy can also be performed through operative laparoscope. The medical treatment options are that is indications are unruptured tubal pregnancy less than 3 cm, absent hemoperitoneum, sonographically non-viable pregnancy, and beta HCG level less than 2000. Then methotrexate orally or injected laparoscopically is given. Prostaglandins PGE2 and PGF2 are locally injected at the site. Mifepristone, that is anti-progesterone, used for the termination of pregnancy of ectopic pregnancy, and hyperosmolar glucose actinomycin D at 20% potassium chloride is given. Expectant treatment is the monitoring of HCG to fall and follow up. So we have discussed the topic, the ectopic pregnancy. So first of all, we have discussed that what is the scenario. There is a patient who arrives with the abdominal pain and the spotting PV, and she is 6 weeks pregnant. So ectopic pregnancy is the implantation of fertilized ovum at the site other than the uterine cavity. The sites are the fallopian tube, and the ovaries, the abdominal cavity. The rare sites are broad ligament rudimentary horn of the uterus. The causes are pelvic inflammatory disease and tubal surgery. Conservative surgery for ectopic pregnancy, sterilization and tubal reconstruction. Then tubal disease, intrauterine contraceptive devices, ethyl diethylstilbestrol exposure, termination of the pregnancy, assisted reproduction techniques, and ovum transmigration. The differential diagnoses are ectopic pregnancy, spontaneous abortion, corpus luteus hemorrhage, appendicitis, and fibroid, subserous fluids, ovarian pathology. The clinical features are amenorrhea, abdominal pain, vaginal bleeding, and other are shock, that is subjective symptoms of the pregnancy, syncope, and shoulder pain. The investigation should be done, which are general physical examination, tachycardia, hypotension, hypovolemic shock, blood pressure, skin pale, and cold climb. This should be checked. Abdominal examination is done, pelvic examination, ultrasound. On ultrasound, the abdominal, vaginal, and Doppler, all ultrasounds are done. Serum HCG is checked, and this is very accurate test as compared to the urine HCG. Laparoscopy is done, which is indicated in difficult cases, or when serum beta HCG or vaginal ultrasound. Colpotomy is done, which shows intraperitoneal hemorrhage, and progesterone is checked. The depressed level of progesterone are present in ectopic pregnancy and a level of below 50 nanogram per ml. The pre-treatment investigations are FBC, assessment of degree of anemia, blood grouping, and research prophylaxis. The management options are conservative, medical, and surgical. So the surgical management is a choice of treatment. The initial measures to be taken are that it is medical emergency, so the patient should be resuscitated. A wire board cannula should be inserted, and take blood from patient and send it for routine investigations. Average blood and start blood transfusions. Monitor vitals, place urinary catheters, and manage hemorrhage of shock, or then give local anesthesias if required. Laparotomy is done, which are indicated in tubal pregnancy ruptured and patient hemodynamically unstable. When laparoscopy is contraindicated when ectopic pregnancy is in cone or rudimentary horn of the uterus. Then give small fenestrial incisions, and laparotomy is indicated if there is tubal rupture. The corrective procedures are salpingectomy and tubal repair. In salpingectomy, partial salpingectomy and salpingotomy is done. The laparoscopic surgery, bull salpingectomy, and conservative procedures performed at laparotomy can also be performed through operative laparoscope. The medical treatment are indicated when there is unruptured tubal pregnancy and absent hemoperitoneum and sonographically non-viable pregnancy at beta HCG level less than 2000. Methotrexate, prostaglandin, and mifepristone are given in medical conditions, and hyperosmolar glucose actinomycin D and 20% potassium chloride is given, and the expectant treatment is the monitoring of HCG to fall and follow up. Now coming towards the next topic, that is endometriosis. Okay, now the next topic, that is endometriosis. So for endometriosis, we are having a scenario that define endometriosis, enumerate the common signs and symptoms, and the disease management of extensive endometriosis, the management of mild to moderate endometriosis. Okay, another scenario is that there is a 30-year-old multiparous married since 9 years, present with pelvic menstruation and dyspareunia. So what are the diagnoses? The write down the theories, the clinical features, the gold standard investigations, the management, the treatment, and the surgical options. Okay, so for endometriosis, we are having specific theories. We will discuss this all also. Another scenario is that there is a P2 presented with secondary infertility, dysmenorrhea, dyspareunia with adnexal solid mass with pelvic adhesions. So, what are the differential diagnosis, investigations, and the management? So, the definition of endometriosis is that it is defined as a condition in which the tissue structurally and functionally similar to endometriotum is the part present outside the uterine cavity. Okay, what happens that a tissue similar to the endometriotum structurally and functionally similar to endometrium is present outside the uterine cavity. Now, what is adenomyosis? So, when the same tissue is present within the myometrium, it is called adenomyosis. The sites for endometriosis are pelvic organs, bowel, urinary tract, and other sites. The causes are exact causes unknown, and various theories are present for this endometriosis explanation. The first one is retrograde menstruation and implantation theory, which is also known as Samson theory. It illustrates that menstrual bladder not only flows downward through cervix but also flows backward through fallopian tube into pelvic cavity and blood gets implanted there. Another theory is that lymphatic and vascular dissemination, that is Halban theory. According to this theory, endometrial cells enter open basal lymph and blood vessels at the time of menstruation and are then embolized to ectopic sites. This theory explains endometriosis at distant size. Then we have the transformation of coelomic epithelium cells, which originally differentiate from coelomic epithelium, undergo differentiation back to their primitive origin and then transform into endometrial cells. Then we have autoimmune theory. Antigens are produced by degradation of the endometrial proteins, and anti-endometrial antibodies have been found in higher concentration in women suffering from endometriosis when compared with the normal woman. Then we have composite theory, that is endometriosis is not caused by single mechanism and etiology of endometriosis is multifactorial. Okay, so these are the different theories. That is the retrograde menstruation and implantation theory, Samson theory, then lymphatic and vascular dissemination theory, that is Halban theory, then the transformation of the coelomic epithelium, the autoimmune theory, and the composite theory. Now, what are the clinical features of the endometriosis? These are pain in relation to the site. Pelvic organs pain is dysmenorrhea, dyspareunia, dull lower abdominal and pelvic pain, lower backache, and acute abdomen. Infertility is there and menstrual irregularity is present. The GIT clinical features are cyclical tenesmus, rectal bleeding, diarrhea, and colonic obstruction. The urinary tract clinical features are cyclical hematuria and pain and ureteric obstruction. The surgical scar and umbilical clinical features are cyclical pain and bleeding. And okay, now coming towards the differential diagnosis. So, in lungs, we are having the cyclical hemoptysis and pleuritic pain. Now, coming towards the differential diagnosis, which are adenomyosis, pelvic congestion syndrome, fibroid uterus, intrauterine contraceptive devices, endometrial polyp, ruptured chocolate cyst, and acute salpingitis and torsion of the ovarian cyst. The investigation options that are done for endometriosis are laparoscopy, that is the detailed examination of the pelvis, then ultrasound is done which can detect the chocolate cyst and lump of high dense level echos, and serum carcinoma, that is 125, which is raised in the patients with endometriosis. CT scan and MRI is done which pick up the small lesions. The treatment options for the endometriosis is that it can be treated with drugs and surgery which can be either used alone or in combination. The medical treatment options are indicated when minimal moderate diseases within the pain and infertility. Drugs, danazole, oral contraceptive pills, progestin only, gestatinone, prostaglandin synthase inhibitors, and gonadotrophic releasing hormone analogs are given. Surgical treatment is indicated in endometriomas, pelvic adhesions distorting pelvic anatomy, blocked fallopian tube, incapacitating pain in volume of other organ system. The conservative surgery is indicated for fertile unmarried, ovarian tissue is preserved and tubal patency is restored by fibroplasty or salpingostomy, can be performed at laparotomy or laparoscopically. The radical surgery is indicated in menopause and to complete family. Excision of the endometrial implants, hysterectomy, and bilateral oophorectomy is done. The combined medical and surgical treatment is hormonal therapy and given before and after surgery. So we have discussed the topic the endometriosis. That what is endometriosis? First, we have discussed the scenario that defined endometriosis, enumerate the common causes and symptoms, the management, and the management of extensive endometriosis and management of mild to moderate endometriosis. Okay, so the definition is that it is defined as condition in which tissue is structurally and functionally similar to endometrium is present outside uterine cavity. Then what is adenomyosis? It is the stem tissue is present within the myometrium. Then it is called adenomyosis. The sites are pelvic organs, bowel, urinary tract, and other sites. The causes are exact causes are unknown, and various theories are there. So these are retrograde menstruation and implantation theory, lymphatic and vascular dissemination theory, transformation of the coelomic epithelium, autoimmune theory, and composite theory. The clinical features are pain, that is in relation to the site, and then GIT clinical features, the urinary tract, the surgical scar and umbilicus, and the lungs. Then we have discussed the differential diagnosis, which are adenomyosis, pelvic congestion syndrome, fibroid uterus, IUCD, endometrial polyp, ruptured chocolate cyst, acute salpingitis, and torsion of the ovarian cyst. The investigation options are laparoscopy, ultrasound, serum, carcinoma of 125, CT scan, and MRI. Then the treatment options are the medical treatment, which is indicated when minimal moderate disease with pain and infertility. Then drugs are given, that is dronazole, oral contraceptive pills, progestin only, gestinon, prostaglandin synthase inhibitors, and gonadotrophic releasing hormone. Surgical treatment is indicated in endometriosis when pelvic adhesions, distorting pelvic anatomy, pelvic block fallopian tubes, incapacitating pain, and involvement of the other organ system is present. The conservative surgery is indicated for fertile and unmarried. Ovarian is present and tubal pregnancy is restored by fibroplasty or salpingostomy and can be performed at laparotomy or laparoscopy. Radical surgery is indicated for menopause patients and complete family. It involves the excision of the endometrial implant, hysterectomy, and bilateral oophorectomy. The combined medical and surgical treatment is hormonal therapy given before and then after surgery. Adenomyosis is also a type of endometriosis in which the endometrium implant in the myometrium, and the clinical features are menorrhagia and dyspareunia and pelvic discomfort, pelvic mass, bladder and bowel symptoms, and pelvic examination. The investigation, specific investigation is ultrasound, and the treatment is symptomatic treatment plus surgery plus hysterectomy. Same is that of endometriosis, but it is a little bit different that it is a specific case of endometrium in which it implants in the myometrium. Okay, so here we have covered the topic, the ectopic pregnancy, which is one of the major topic from the gynecology subject, and endometriosis and adenomyosis. Okay, these topics are covered: ectopic pregnancy, endometriosis, and adenomyosis. In the next video, we will discuss the UV prolapse, the infertility, and the contraception. And then in the today's third session, we will discuss the PCOS, the gestational trophoblastic diseases, and the benign diseases of the uterus and fibroids. Thank you so much for watching, and don't forget to subscribe this channel for upcoming videos. Thanks for watching.